Quotes, I think. So this is the one of the talk which I am going to talk to you. This talk is about the NOACs. It's 10 years of NOACs learning and the future implications. Uh, Nothing to disclaim. Basically, when we talk about the atrial fibrillation and the venous thromboembolism, the anticoagulation play a very important role. And we all know the limitations of the VKA, that is the warfarin and the acetrom, where the predictability of a response and because of that thrombosis and the hemorrhage is more common, and because of that in our practice we were looking for something new drug, and I think the NOACs has replaced that in a non-valvular atrial fibrillation. Whenever we see a patient of paroxysmal atrial fibrillation or a chronic atrial fibrillation, I think we are always worried about that the patient will develop a stroke or systemic embolism or not, and how do we prevent that? And when we prevent that, how do we, because the side effect of the anticoagulants is the hemorrhage, and how do we reduce that hemorrhage, or what is the molecule that will help us to reduce the intracranial hemorrhage? So you can see that this is a slide where the NOACs has showed a benefit risk profile versus warfarin, 19% reduction in stroke and systemic embolism, and compared to warfarin, reduction in intracranial hemorrhage was almost 52%, 14% reduction in major bleeding, and 25% increase in the GI bleeding was seen in some patients. If you look at the non-valvular AF, different clinical trials, that is Aristotle, Apixaban, Rocket AF, Rivaroxaban, Engage AF, where there was Indoxaban, really it was a dabigatran, and the combined, if you look at all these trials, overall intracranial hemorrhage or hemorrhagic stroke was reduced by roughly half, representing a substantial benefit treatment with the DOACs. And whenever the patient is elderly or 75 years old and we want to use an anticoagulant, it's always a worrying that the patient will have a hemorrhage or what. And there I think compared to a warfarin or the acetrom, these drugs have shown that the hemorrhage is less in the elderly patients also. This is the Aristophanes where the consistency findings were on the different RCTs overall, and in older patients, the systemic embolism and the stroke were reduced by almost 25 to 30%, and hemorrhagic risk or intracranial hemorrhage was less in these patients. So, ESC-AF guidelines say that for stroke prevention in atrial fibrillation, patients who are eligible for OF, NOACs are recommended in preference to VKS, that is a class 1A indication. And there I think the adherence, patients training, education and counseling becomes important. Whenever we use a VKA, always PT-INR monitoring is important, and when we do a PT-INR monitoring, we know that the predictability and the fluctuations of the INR is very common, and because of that we need to monitor these patients very well, and we need to train our patients to do a PT-INR and how do we adjust the dose of warfarin, and that's what goes away with the NOACs where there is no monitoring required. And when we treat a patient of atrial fibrillation, there are challenges and the evidence gaps in the uptake of anticoagulation, which I talked about. In mechanical heart valves or a rheumatic valvular disease, still it's a VKA we need to use. And as I said, that the knowledge about the physicians, screening of the patients and treating the disease, it becomes important, and where education is important. And how does NOAC score over the warfarin? No dietary restrictions. When we give a warfarin, vitamin K rich foods needs to be avoided. Very few drug interactions, reduced comparable stroke and major bleeding risk compared with warfarin. Perioperative bridging is not required. Whenever we use a warfarin or acetrom, I think the 5 to 7 days is required to stop the drug. Here, 24 hours we can stop the drug and patient can be taken for an emergency surgery. No anticoagulation, monitoring is required, as I said. And whenever we use a warfarin, the bone fractures are common. Whenever the patient has a liver and a kidney problem, then we need to do adjustment of the drug very properly because the bleeding risk goes up. As I said, fractures, it's greater. This is the one slide, it's very important, developing a diabetes. We talk about the statins and developing a diabetes. Similarly, they say acetrom, warfarin, patient will develop a diabetes over the period of 5 years, which is less with the NOACs. Whenever we are using a warfarin or acetrom, renal function becomes important, and the NOACs, we have 3 to 4 different drugs, but they say that the apixaban is better in the patients with the renal failure. And As we all know about the atrial fibrillation, wearable devices are very important. The Alvicor, Genicor ECG machines that is the first bit, and nowadays it's watches where the atrial fibrillation can be detected with a single lead ECG, and the sensitivity and specificity is increasing with these devices. And basically undiagnosed atrial fibrillation, which are the patients who are going to develop atrial fibrillation? How do we identify as subclinical AFs? Because most of the stroke patients, we do a Holter monitoring, many times we don't find atrial fibrillation. So these subclinical AF patients, elderly patients, patients having a hypertension, LV hypertrophy, diastolic dysfunction, left atrial enlargement, all these patients are prone for developing atrial fibrillation. So frequent monitoring is required to detect about the atrial fibrillation so as to decide about anticoagulation. Because if they fall in a high-risk patients, do we really give a NOACs to them or not, needs to be decided. This is how we have a chart.
3 forceps, Ellen.
Score, low risk, moderate risk,
There's the blade.
high risk, and depending upon the risk
So I
score,
pushed it back 5 minutes. So we've got 20 minutes to get
prone
everything
for
all set up.
developing
It's
atrial
going well.
fibrillation.
They're probably
And
running.
if
They're
they
running
high
late
risk
anyway.
group,
Yeah,
They're
we can
going to
use
cut their break short. So I
anticoagulation
said, well, there's no
these
need for that at the
patients.
moment.
There's no rush here.
Second part is a venous thromboembolism. I think we all are using NOACs for DVT. Many times in our practices, what we are doing is that treating these
Orange is
patients
okay?
for the 5 days with a low molecular weight,
Can I have
heparin
some
or
more
a
lignocaine?
quaterpirinox, and then shifting them on an oral anticoagulant.
I'll let you know if there's
But
any
whenever
update
there
with
is
the
a no
time.
interventional treatment required, they are recommending that the first day
More
you can
lignocaine?
start the NOAC,
So I think
and the
that's
patient
what I
can
would
be
actually
treated on
do
a
rather
OPD
than introduce
basis.
the team at the end. Is while we've got the camera and I'm over there,
So
I'll
these are
introduce
the
everyone in the
different
room.
trials, and I think in our
And then I'll come
practices,
over
we
here.
all are using 3 to 6 months
We've got-
NOACs for the treatment
well,
of
then
the
I mean,
VT.
then we'll go to the slides. Can you advance the slides yourself?
And depending upon the,
Or
after
can I? Shall I
stopping
just-
the
I'll just come over here and
NOACs,
just
we can
do
do
it
a
manually. Yeah,
thrombophilia test, and depending upon that, we decide that this patient is going to require a lifelong anticoagulant,
They've got no
or they are
feedback
going
yet.
to require it only for 6
So,
months.
no feedback
Recent
yet.
guidelines, we know that the chest in patients with VT, we recommend apixaban, dabigatran, indoxaban, or rivaroxaban, or VK as a treatment phase first 3 months anticoagulant therapy.
There you go.
Cancer-associated VT, whenever the high-risk patients who are on the cancers and they feel that the patient is going to develop a thrombosis, NOACs can be started, or if patients develop a thrombosis, these drugs can be used safely. This is what the guidelines talk about in the cancer. In patients with cancer-associated thrombosis, we recommended an oral 10A inhibitor or LMWH for the initiation and the treatment phase of therapy. And most important thing, whenever we want to use the
The two
anticoagulant,
guys, please.
psychosocial factors
Done the
becomes
region?
very important. We need to teach people and the family members
Okay,
that
very
this
happy
is
with that.
very important.
Do you have
that
a
if
wet
patient
swab,
is on
please, Ellen?
anticoagulant,
Just to wet the
chances of
probe light.
developing a
Thank you
thrombosis
so much.
or a bleeding risk is there, gastrointestinal or intracranial hemorrhage, and there I think the anxiety, fear of future, life-changing or traumatic things are important, and there I think the communication becomes very important, and I
You
think
want to do
that's
over
the
the
important
ultrasound?
part of
We
our
left.
practices. So recommendations are,
Okay, check your
we
wire.
need to discuss the treatment options with the patient and basing anticoagulant choice on their clinical feature and preferences. Goal of VAF and AF and the VT treatments is to enable patients to overcome barriers and support self-management. And as I said, communication skills are important for a successful clinical outcomes. So to conclude, we are in the new era of anticoagulation with NOACs. We need to embrace this era, and patients are at risk even when treated with traditional therapies. And as we know that apixaban is effective and the intracranial hemorrhage or hemorrhagic stroke is less with that, there is a preferred molecule for treating a patients with atrial fibrillations, and the VT. Similarly, dabigatran and rivaroxaban are as effective as warfarin. We are reducing the
Mr. Wire?
stroke and the systemic embolism in non-valvular AF with a low risk of intracranial
Yep.
hemorrhage with nanowarfarin. Thank you very much.